Good evening, one and all. On behalf of Dr. Agarwal's Institute of Optometry, I extend a warm welcome to each and every one of you for the 49th episode of Optometry Series. I would like to thank my team members, Ms. Meenakshi and Ms. Anshi ma'am. Hi, both of you. Thank you so much for your continuous support. I would like to extend my support to all the audiences who is giving us continuous support, especially to the Back to Basics series. And at this eighth part of the Back to Basics series, we're going to see how to document the entire case. And Anshi ma'am, would you like to add on so why is today's topic? So what is the importance of today's topic?
So as we know that we have completed almost all the sessions on back to basics. So today we would like to wrap up the entire session. We started from the first initial procedures like history taking to now we are going to end up with how do we write diagnosis management and what is actually closing of a case. And when we start learning about how each procedure is done, how each documentation is done, and how the importance of putting all that in a file is what we are going to read about today. And Aisha is expert. Been handling so many patients for so many years. So my senior, with a lot of inputs that we get from her, I think she would be the best one to explain to us why even negative history or even positive history or why each documentation is important. So over to the MC to introduce our moderator for the day, Aishwarya.
Good evening, everyone. I am Mahalakshmi, a third year bachelor's in optometry at Dr. Agarwal's Institute of Optometry. I am very happy to welcome our today's moderator, Dr. Aiswaryah Radhakrishnan ma'am. Ma'am has completed her bachelor's degree in optometry and MPhil in clinical optometry at the Elite School of Optometry, Chennai. She completed her PhD in optics, optometry, and vision in 2016 from Spain. Ma'am has extensive experience as an optometrist and lecturer in the Department of Corneal Diagnostics and Refractive Surgery at the Medical Research Foundation, Chennai. Between 2012 and 2016, she worked as a researcher at the Visual Optics and Biophotonics Department, Institute of Optics, CSIC, Madrid, Spain, and as a postdoctoral research fellow at the Image Processing and Computer Vision Lab, Indian Institute of Technology, Madras. Currently, ma'am is working as an associate professor in the Department of Optometry at SRM Institute of Science and Technology since 2018. Ma'am has 26 publications in peer-reviewed national and international journals. Her areas of research in interest include the impact of ocular optics on visual perception, visual processing, and compensatory mechanisms in the eye, optical instrumentation, and ophthalmic design, image processing and blur compensation in the human visual system, underwater vision, sports and occupational vision. She shares a patent from SRM Institute of Science and Technology for an apparatus for a portable headset. Ma'am has won various awards, scholarships, and grants for her paper presentation. She has awarded a startup research grant by the Science and Engineering Research Board as principal investigator in 2019. She also received the PFA travel grant by the Council of Scientific and Industrial Research in 2022. We are truly grateful to have you as our moderator today, ma'am. Thank you so much for joining us. The presenters for today are Ms. Divyadharshini and Ms. Padmashri of second year bachelor's in optometry at Dr. Agarwal's Institute of Optometry. Ms. Padmashri, please start your presentation.
Thank you, Maha. Good afternoon to everyone. Myself Padmashri, second year student of Dr. Agarwal's Institute of Optometry. Today we're gonna see about case documentation, case history. A 19 years female came with a chief complaint of blindness, blurring, and diminution of vision for distance since 1 month with glasses. No other specific ocular complaints. Previous ocular history of glasses since 13 years. No history of trauma or surgery. General history, the patient has no history of diabetes mellitus, hypertension, or any other systemic illness. Family history was not contributory. Recent investigation and current medications are nil. The patient was not aware of allergies. Previous glass prescription since 2 years. Single vision. For right eye, minus 3.50 DS and minus 1.75 DC across 110 axis. OS, minus 3.25 DS and minus 2 DC across 85 axis. Visual acuity should be done for both distance and near. So with RX, the right eye has 6 by 12 plus 2 with pinhole it is 6 6, and for left eye 6 by 12 with pinhole it is 6 6. For near vision with RX, the right eye has N6 at 40 centimeter, and for left eye it's 16 at 40 centimeter. For objective refraction, the right eye has minus 5.00 ds and minus 2.5 dc across 110 axis with clear glow. The left eye has minus 5.25 ds and minus 2.50 dc across 85 axis with clear glow. The acceptance was for the right eye minus 5 ds and 2 dc across 110 axis with 66 and n6, and for left eye minus 5 ds and minus 2 dc across 90 axis 66 and n6. Fogging and JCC are done and diaphragm green better. Since the PGP and the objective refraction value has drastic changes, cycloplegic refraction was done. So for that, right eye has minus 4.00 ds and minus 2 dc across 110 axis, and for left eye minus 4.50 ds and 2 dc minus 2 dc across 85 axis. The acceptance was OD minus 4.50 ds and minus 1.05 dc across 110 axis, and for left eye minus 4.50 ds and minus 1.75 dc across 85 axis. Fogging and JCC are done. Diaphragm was balanced. For EOM, the patient was noticed that she has no any ocular motility restriction or palsy. So both eyes she had full free and painless. Pupil examination without accommodation, reacting to light was noted, and with accommodation, perla was noted, and no RAPD. Cover test was done and Hirschberg test was done. For distance and near, noted as ortho. Confrontation, both eyes are normal. For IPD, distance for right eye 30 mm, left eye 31 mm, and OU 61 mm. For near, OD 29 mm, OS 28 mm, OU 57 mm. Slit lamp examination, the upper lids look normal, cornea was clear, and ACD grade was 4. Lids RPS normal, both lenses are clear. Intraocular pressure 1 pm with 80. For right eye, it's 12 mm Hg, and for left eye, it's 14 mm Hg. Fundus examination, the margins appear normal, and the cup disc ratio was 0:4. Fovea macula on. In case of myopic fundus, findings to be documented with color codings. Diagnosis, myopia and astigmatism. Advice and precaution, new glasses with regular checkups, screen breaks, outdoor activities. Thank you.
Thank you so much, Padmashri. It was an elaborative presentation on how to briefly document things, whatever we measure correctly. Now I request Aisha ma'am to add your inputs. Though it is a normal case, what should be emphasized more from the optometric perspective? And now is the refraction playing a key role in myopia?
Keratometric performed for this patient.
Ma'am, your voice is very low, ma'am.
Was
We couldn't
keratometry
hear.
performed for this patient?
Sorry, ma'am.
Keratometry?
Keratometry was not performed, I guess, ma'am.
So that is one important aspect. I know we are not talking about refraction here, but this being a, can you hear me well?
Yeah, ma'am. It's good now.
Okay, so this being a patient with significant cylinder, that's one aspect I found was missing in this case. And why it is important is especially when we know this is right now at 180, but later on, if this patient is going on to go in for keratoconus or any other ectatic condition, so initial documentation of keratometry would be a good thing. And also because the astigmatism is significant, it will be a great indicator. So that's one aspect I just wanted to point out. What was your question, Meenakshi?
Am I audible, ma'am? Yeah, we know it is just a myopia case, but then as an optometrist, what should we more concentrate on? How negative history plays a major role, or what is the difference between the cycloplegic and the dye retinoscopy? How do we come to a conclusion of acceptance? Those things, ma'am.
Okay. So as a
as an optometrist for a myopic case, I think the diagnosis starts right from the history. So the family history and whether one or both of the parents have a significant family history of myopia and how it runs. At what age did the child start wearing glasses? Because we now see that it is a change in refraction, but at what age did the girl start wearing glasses? These things should be documented in the history, because later, if we want to put this patient onto different measures for controlling the progression of myopia, or this being the cusp age after which the patient might go in for a refractive surgery, the history comes into play, and it's going to play a major role. The second aspect of it, refraction in this age group for a myopic patient is not going to be too much of a trouble unless we have the pseudomyopia playing a role. So cycloplegic refraction in an adult myope has, while it does have a role, the most important factor I would say is to perform an MEM over the subjective refraction, even with the dry retinoscopy and the dry acceptance, and then consider a cycloplegic refraction. And usually the rule is, if there is nothing wrong, don't change it. Someone with no complaint regarding vision, we shouldn't be ideally going in for, a change in refraction, whether through a cycloplegic refraction or not. So those are my points here.
Thank you so much, ma'am. Can we see the second case, ma'am?
Yeah.
Thank you, ma'am. Divyadharshini, requesting you to start presenting your case.
Sure, ma'am. Okay, let's have another case history. A patient with 46 years old male has come with a complaint of routine eye checkup, and he was a spectacle wearing patient since 2 years, and he has no history of trauma or surgery. General history was he had a history of diabetes and hypertension since 2 years, and he was under medication. Family history was not contributory. His recent investigation and current medications was nil. He was not aware of any allergies. Previous grass prescription since 1 year was OD plus 0.50 spherical with minus 0.75 cylinder across 100 axis. For left eye, it was plus 0.50 spherical with minus 0.50 cylinder across 110 axis. For both the eyes, add was plus 1.25. Visual acuity examination was done, both distance and near, and the distance for right eye was 6/9, no improvement with pinhole, and for left eye 6/6 with pinhole, it was 6/6. Near visual acuity was done with RX. OD was N6 at 40 centimeter, and for OS it's also 40 centimeter. Objective refraction value was for right eye plus 0.50 spherical with minus 0.50 cylinder across 100 axis with clear glow. For left eye, it was plus 0.50 spherical with minus 0.50 cylinder across 110 axis with clear glow. Acceptance value was found to be plus 0.50 spherical with minus 0.50 cylinder across 100 for right eye with a vision of 6/9 with N6. For left eye, it was plus 0.50 spherical with minus 0.50 cylinder across 110 axis with a vision of 6/6 and for near N6. Diachrome was found to be balanced. Extraocular motility was performed and the patient was found to observe full, free and painless movements. Pupil examination was done, and for both right and left eye, no RAPD, PERLA or RRTL. Slit lamp examination was performed and the patient was found to be normal with normal lids. Cornea was found to be clear. ACD grade 4, lids were normal and with both lenses clear. Intraocular pressure was performed at 2:15 p.m.
with applanation tonometer. OD was found to be 14 mmHg and for left eye it was 18 mmHg. Fundus examination was performed in a dilated condition. Margins were found to be normal with a cup disc ratio of 0:4. OCT image was taken and the fundus was found to be normal. Diagnosis: the patient was diagnosed as mild hyperopic, astigmatic and presbyopic patient for both the eyes and he was advised for regular checkups. After 10 months, the patient has come with a complaint of painless blurring and diminution of vision for distance since 1 month with glasses. Again, visual acuity was performed. For right eye, the distance value was 660 with no improvement with pinhole and near was N36 at 40 centimeter. For OS, the distance was 66, near was N6 at 40 centimeter. Here, the vision has drastically deteriorated. IOP was found to be 22 mmHg for right eye and for left eye it was 25 mmHg. Fundus examination was done and in right eye the media was AC, neovascularization was at the level of disc, multiple blood vessels were seen, vitreous hemorrhage was fresh and the fundus has a high risk for PDR. For left eye it was macular microaneurysms were present, hard exudates, hemorrhages and vitreous hemorrhages was present. Lesions were at the level of periphery and fundus has a risk for PDR. Diagnosis: the patient was diagnosed as presbyopic, unspecified diabetic retinopathy with macular edema and vitreous hemorrhage was also present. Investigation was found to be fundus photo for both eyes, OCT for both eyes, B-scan, FFA and FA for both eyes. He was advised to have anti-VEGF, that is vasoendothelial growth factor, VIT or laser. After reports, treatment were up to done. And the follow-up too was, as advised, laser, that is pan-retinal photocoagulation was done and the fundus media was clear. Very hazy optic disc was found and the fundus was present with attraction between vitreous and PDR. Diagnosis: diagnosed vitreous hemorrhage in right eye. He was advised to do vitrectomy, intravitreal injection, retinal laser photocoagulation. IV injection done and vitrectomy was planned. Examinations: visual acuity was tested and for right eye, uncorrected vision was 3/60 and no improvement with pinhole and for left eye it was 6/6. After intravitreal injection and vitrectomy, vision in right eye improved to 624, but left eye vision gets to 660. The vision was greatly reduced. Thank you.
Thank you so much, Divya. We know that it is a diabetic retinopathy case. Aisha ma'am, you want to emphasize on any necessary documents that has to be made or any comments on the documentation purpose as such, ma'am?
One, she has rightly mentioned. Can you hear me? Yeah. Okay. So, I mentioned the fundus documentation should be done with appropriate color coding. Color coding plays a very important role because nowadays with many things moving on to EMR and having drop-down buttons to document certain things. On the other hand, color coding helps us know the exact location and the extent, both lateral and the position and the extent of the abnormality, whatever. And we know that there are 6 different colors which are used for different disease or different lesions, like hemorrhages have red color and attached retina has a light blue and stuff like that. So using these color codings, even if one is not able to decipher what is written, we can find what is being the finding. So, and second thing, I think this is a very good forum to emphasize. Diabetes is a condition that has lots of repercussions in the eye specifically. And us being the forefront primary healthcare practitioners, we should have some sort of referral guidelines as to how frequently follow up the diabetic patients, how frequently should the fundus examination be done, the dilated fundus examination be done, and will help for example, in this case, the patient has returned in 10 months, and it was possible to catch the diabetic retinopathy changes at an earlier stage. So that is very important. And yeah, any follow-up questions?
With the documentation perspective, ma'am, would you like to emphasize or add any points? This documentation could be made in this way so that the better understanding can be given about the case.
Okay, I do have lots of questions right from the PTT, but not taking that up. Maybe I will give some general comments, starting right from the history. Negative history is very, very important, especially even if it is a patient who is coming for a regular checkup. Unless we document that the patient does not have certain symptoms, and one doesn't know if the patient, whether the patient reported these symptoms to us or whether we have asked the same. We could be extremely good optometrists having a very good rapport to the patient, having a very good flow of history taking, but documenting the negative history, especially in diabetic patients, to ask if they have floaters, even the strange ones, it is important to document the floaters and black spots, whether it's present or absent, uh, right out of the way. So history flow should go like what was their main purpose of visit. So that's the chief complaint, right? And following which the first sentence usually reflects whatever they have come for the purpose of visit. The I, the complaint, and the duration. That forms a very important part of the history taking. And personally, from my training as well as from the way we read history, personally, I feel whatever is the chief complaint, following that, it should be the associated complaints with regards to the chief complaint. And then we ask about what was the vision related status, whether it's for distance or for near, whether it's overall foggy, overall hazy. Those complaints should come in place, and this is the best place to document if they're seeing anything strange in the visual field itself. The next set of complaints should come from the anterior segment. So one, how the patient sees. The next set of complaints are from the anterior segment, whether they have anything itching or irritation or redness with respect to this, what it is. The third one would be related to the posterior segment, which will be flashes of floaters. So whether it's present or absent should be specifically documented. Once this is done, then goes the past ocular history. So in the past ocular history, again, I'm sure you have had your back to basic history taking, but uh, purely speaking from the point of view of documentation, all relevant past ocular history and history for that matter in patient's own words, as much as in patient's own words as possible should be documented. And then in the past ocular history, we see nowadays vague documentations of history like patient wearing spectacles or parents wearing spectacles. The very reason we are asking whether they wear spectacles is to know if there is a hereditary component, mainly for myopia or high astigmatism for the patient who inherited. So the history should communicate this when we document it. We cannot simply write that the patient's parents wear wear spectacles because that could be presbyopic spectacles also. So parents are myopic and have been wearing myopic spectacles, or patient has been using spectacles for distance visions in such and such case. That which communicates what kind of refractive error for which they use the spectacles. Um, and also, when it is a patient with diabetes, it is important to note down if the blood sugar level, not just the recent investigation, the past 3 months investigation, but whether the patient has been having good control of blood sugar for the recent years, because there are patients who have had diabetes for 2 or 3 decades and still do not show any fundus changes, mainly owing to many of the factors, but primarily the glycemic control. So that should be documented in specifically in relationship to this case, the glycemic control and any medications that are pertinent, both ocular and systemic. And us as optometrists should know what medications are given for basically for what systemic diseases, so that we know that, when the patient says they are not clueless as to whether it's given for hypertension or diabetes, because right now the patient could be feeling all right and they may say, my health is good, and then they'll suddenly say, I'm taking point of mg of standard. So we should know for what conditions they're taking medications and what medications correspond to what. So pretty much that is with history. With PGP, I saw this was a case which used progressive, and the previous case also, which was a single vision glass. The PGP should document also the status of the spectacles, whether there are any scratches or the spectacles are in good condition. That should be documented. Am I taking too much of your time, Meenakshi, or shall I go ahead? We'll continue. Yeah. Okay. So the next aspect is the visual acuity checking, right? So visual acuity checking, we usually have lots of confusions as to what to document, and I'm so happy to see both these presentations. They are mentioning what type of chart they have used and at what distance these charts are used. So that is very important in my opinion. And also the pinhole visual acuity, but also the binocular visual acuity is important because sometimes a patient who is having a change in refractive error in one eye may not be symptomatic binocularly. So binocular visual acuity documentation is also important. When it comes to near vision, it is N6 at 40 centimeters, like how visual acuity is tested at 6 meter. And when the visual acuity is not, when the patient is not able to see even the biggest letter at 6 meter, we move to closer distances. We usually test near vision at 3 diopters of accommodation. So that's at 33 centimeters. And if we are testing at a different distance, then it is mandatory that we mention if it is the patient's comfortable working distance, or if or was there any specific reason why the visual acuity was tested at that specific distance. For example, an uncorrected myope may be able to read it only at closer distance. So that has to be documented why a different working distance was opted for that specific patient. What else? So refraction, refraction, how the glow was is important. Slit lamp in diabetic cases. In addition, we have to document whether you see any neovascularization or if you don't see any neovascularization. That is super important. Jumping from refraction to slit lamp, but the diabetic cases, I saw this one had a good glycemic control. So any change in refraction, uh, it can be attributed to the fluctuations in blood sugar level, or it could be true change, or it could be the change that is triggered by the cataractogenesis secondary to diabetes. So these things we have to consider in refraction, and maybe we can give an opinion on why we think there is a change once the subjective refraction is done. If I can ask, the previous case, there was for a 0.75 diopter difference in refraction, the patient still had a balance of diopters. So that was something that I don't understand. So maybe
Present
I'll,
is
that was Padmashri.
present is. Are you there? Yes, ma'am.
Yeah, Padmashri, do you know why this patient had, pre-cycloplegic refraction for almost as a spherical equivalent, 0.75 diopters of overcorrection, and still the duochrome was balanced, but post-cycloplegic refraction, that is in the PMC with minus 0.75 diopters from the original correction, the duochrome was still balanced. Do you know why?
Sorry, ma'am, we didn't see.
I couldn't hear you well. Can you repeat it?
Sorry, ma'am, we didn't see.
No, you have presented in acceptance with both eyes minus 5 diopters of refraction spherical power. And I know you're just in your second year, right? So you must be starting with refraction now. But you understand the duochrome test for the stages of accommodation, right? Well, maybe that's one point you can look into. A 0.75 diopters of overcorrection will somehow show either there was a larger step of defogging which was involved, or if the patient was accommodating, it will still not show as a balanced duochrome, especially for a 0.75 diopters of overcorrection. So that was one thing I had a clarification to make. So these things we may have to note down. The patient who had a 6 by 12 vision, you do expect, because their PGP was 3.5 minus 3.5 diopters, and with almost 1.5 diopters jump, the patient had an improvement in vision to 6 by 6. That itself is one clue, because we say for every line there is a quarter diopter. Every line and a half, you have a quarter diopter change in myopic refraction. So, so this would warrant to probably 1 or minus 0.75 to 1 diopter of change in refraction. And when that doesn't happen, there itself it should be documented that the patient could be squeezing or accommodating, but which could come up in the duochrome. So that was one thing. What else? So extraocular muscles, again, that's like a Pandora's box. We have 3 different schools of thoughts in documentation, right? It's full-free painless, or you do the broad hedge, or you do the cardinal position, like the radial one. Personally, I think any of that is fine, but you have to check for all the 3 aspects and then document. If you are doing a broad hedge documentation and doing a tick or a overcorrection and undercorrection, full-free painless, if it is accompanied by one of these 2 methods of documentation, which says that there is no overaction or underaction of the muscles in each of these positions, then it is fine. The full-free painless is not wrong, especially if it's a normal case. But again, with twins or pediatric patients, along with that, either with a broad hedge or with a radial line, please document whether there was an over action or an under action, or if it is not there, a simple tick will do to tell us that you did check that. Anything else?
In the diabetic retinopathy case, we saw the vision got fluctuated drastically in 10 months duration. So what could we would have advised them, like regular checkups, or what could prevent that kind of drastic change in the vision?
There is nothing you can do in a diabetic patient if the vision, if they are going in for diabetic. Like we said, there are multiple factors, so we cannot really promise the patient anything. That is why I told you, evidence-based practice is coming into play a lot, and for diabetic patients, if they have diabetes for more than 5 years or so, every 6 months follow-up is now suggested. If they have no fundus changes also, a dilated fundus examination every 6 months is suggested. So you have white papers on diabetic retinopathy or the ETDRS outcomes on diabetic retinopathy that says every 6 months. But in addition to it, we educate the patient to avoid all the other risk factors, primarily the glycemic control, right? And the secondarily to avoid other aspects like smoking or associated conditions like hypertension or maintaining the weight. And then doing a good exercise, some sort of physical activity is also known to release the anti-VEGF factors, exposure to sunlight. So all these can only be education points for the patient, but whether they progress to a diabetic retinopathy or not is something which we cannot say. The second thing we can actually advise the patient is to ask them to notice if they start seeing flashes of floaters and show them by some sort of simulations or educative pamphlets how these flashes and floaters will look. because I think almost all of us see some amount of floaters in some form, some thread-like floating things or black spots when we sneeze, and a patient may not realize that it is an early precursor for the diabetic changes in the fundus. So how does it look in early stages of diabetes? And to check vision in individual eye as frequently as possible, just to compare if the visual acuity is equal in both the eyes is one way we can do that.
Thank you so much, ma'am. It was an extensive explanation about documentation purposes. Anshi, ma'am, do you have any questions for Aishu, ma'am?
Just have last one question, Aishu. Like we started with history taking and we came up to completion of a workup. So how or what take would you give on students for about completing the case? You know, many times what students do is just do till intraocular pressure and leave it. They don't understand what is the importance of writing a diagnosis or a management. So can you give some points on that?
Yeah, I will. Before I do that, maybe I should also emphasize on documenting with proportion. Slit lamp documentation. These things are nicely done. These are second year students, and I think them talking about the importance of documentation is very nice because they are just starting the clinics and they have both done a very good job on that. But when you document certain things, you have to document with proportion. The cornea occupies almost the entire space between the lids. Even when you avert, there is only a small space over there. So drawing a very small cornea or a very large cornea is not really nice. And pupils, the reaction of light to the pupils is also often documented in very weird ways. So that is one thing. And we always document cornea as clear because we look for clarity in cornea, but conjunctiva and other aspects we document as cornea and lens. We document it as clear. The other aspects of the eye we document as normal, right? So that's one thing. Coming to your question, we always have to write the diagnosis, even if it is a patient who has come for a regular eye examination, a pre occupation eye screening, and everything was normal. We have to document that the uh, the examination of the eye and its admixture are normal or within normal limits. That is important because that is when you get a closure. Otherwise, we just do things, we put things in an order in which we are expected to do, but we don't get anything valuable out of it, right? So a documentation always starts with it is me who is doing the examination, examined by so and so. That's the first thing, and the date, and then it should end with uh, diagnosing the patient, so appropriately documenting the diagnosis. The diagnosis should have which eye, again, vision related, anterior segment related, posterior segment related. The same flow as your history, your entire workup, it should have the same flow. That's for the diagnosis. The second thing, which is probably not documented very well in the case sheet, is what we talk to the patient. So sometimes the patient feels comfortable with you and may have had hundreds of questions about their condition. And we might have counseled the patients on certain aspects. So a note here and there. Management options discussed. Patient wants detailed explanation. Patient very anxious needs counseling. Things like that. What did we do as a professional, not as a technician or a skilled personnel to do all the measurements, but as a professional putting these things together, what have we told the patient? Like in this case example of diabetic retinopathy, importance of glycemic control explained. So these aspects should be documented in these files. Documentation is, I'm sure many of the colleges, we do insist that upon the uh, students that documentation is important. We, in fact, give 30% of the marks for documentation, simply even if it's negative documentation. It's because of one reason, that's one way we talk to others in professional terms. What I say, it has to be standardly, it should be understood as a standard by every professional who's in the field. Second, it is a medical legal document. So that is where the negative documentation it plays a major role. And we can always say we have asked and the patient has given a negative history and you document it, and the patient goes to some other clinic or even an hospital and they say a new symptom, you can always go back and say, see, I have asked it and they didn't tell me at that time. It's there in the file. So, yes, yeah, I'm going on and on about it.
Yes, thank you, Aishu. That was very comprehensive. So I think it's a, as you use the word closure, a very good closure for our back to basics episode where we started with the importance of history taking, and just doing all the procedures are not important, but documenting them correctly and completing the case is what is important. So even diagnosis and management play equally important roles in all the procedures that we have done. So thank you for bringing it out so beautifully. Thank you, the presenters. You did a very good job. So over to you, Gomati.
Yes, so thank you so much, Hanshi ma'am, for adding that point. So very good job, presenters. And Aishwarya ma'am, we can't find a better person than you. So first of all, thanks Anshika ma'am for roping in Aishwarya ma'am. And thank you so much, Aishwarya ma'am, for joining with us today, ma'am.
It's great to listen to your second year.
Yes, thank you. Thank you, ma'am. Thank you so much. Dear audience, thank you all for your continuous support towards Optometry series. We'll meet you in the next episode, which is the 50th special episode. Anshi ma'am, you're looking forward for the 50th episode, ma'am. I think there has been a lot of hard work rather than the face that is actually coming up. We, Anshi ma'am, and the moderator, of course, we had 50 different moderators, Meenakshi. So many people, our face actually comes in, but there is a very big team that works behind this. So thank you all the technical people. I can see them all next to me in this room. But thank you all so much, people, for your continuous support for bringing it towards the 50th episode. And dear audience, thank you all so much for making it until the 50th episode. Your support has been a very big weapon for us. Thank you so much. Yes, Aishwarya ma'am, thanks for the celebration, ma'am. Thank
Yeah,
you for celebrating with us. Yes.
Good luck
Meenakshi
for
is
your
also
50th
joining.
episode. Yeah, good luck. Very good luck.
Thank you, ma'am. Thank you
Thank
so
you
much.
so much. Bye.
Optometry community, if you like this video, give a thumbs up and share with all your friends. To know more about the happenings at Dr. Agarwal's Institute of Optometry, please go and check out our Instagram, Facebook, LinkedIn, and YouTube page. Thank you all so much. Bye, ma'am.